Welcome to Health Focus. I'm your host, Dr. Scott. October is recognized as National Healthy Lung Month. The medical specialists who assist people with lung disease include physicians, nurses, and respiratory therapists, but we also really believe in empowering individuals so that individuals can take care of their own health. And cigarette smoking is a major challenge in that respect. There are resources available, however, to help individuals who are trying to quit smoking, and that's what we're going to focus on today. You might be wondering, well, how big of a problem is cigarette smoking in the United States today? Well, the Truth Initiative face sheet on tobacco indicates that about 11% of adults in California smoked in 2017. Nationally, that rate was 17%. But up to 5 or 6% of high school students have tried at least one cigarette in the previous month. That's a problem, and we're trying to improve on that. We're trying to address issues related to smoking, to diminish rates of heart disease, lung disease, cancer, and other problems. We believe we can do better, and to that end, we're very fortunate to have with us today a registered nurse from our own UC Davis School of Medicine, Cari Shulkin, and thank you so much for being with us today. We really appreciate it.
Thank you for having me.
And of course, your field of expertise involves, among other things, tobacco addiction. But I believe you're also a certified registered nurse in cardiovascular or vascular medicine?
Yeah. I've worked at UC Davis for over 30 years, and I've always done cardiac nursing. I've done 10 years in the hospital, but when I went out to outpatient in a cardiology department, smoking is probably the most impactful cardiac risk factor, and that's when we decided we need to have a smoking cessation program. And it was developed with one of the cardiologists I work with, Dr. Tisa Capagoda, and we created and implemented a smoking cessation program targeting cardiology patients. And over time, it just has kind of blossomed, and I'm in a patient education department now, and the program goes out to all the outlying clinics at UC Davis.
That's fantastic. And how long about has this been going on, this program?
About 20 years.
Wow, that's a long time.
Yeah.
And I guess, you know, for heart disease, the rate of heart disease is about triple if you smoke compared to someone who doesn't smoke.
Absolutely.
And
it's
also,
imperative to get help.
Right. And peripheral vascular disease, poor circulation to the extremities.
Yes.
So I think it's certainly critical. And that's without even getting into the issue of lung cancer, where the risk is 10 or 20-fold higher.
Exactly.
Yeah. So tell us a little bit more about your program here at UC Davis, Aaron Shulkin, if I may call you Cari.
Yes, please do.
So tell us a little bit more about it, Cari.
So we offer classroom instruction at UC Davis. We have a workshop every month. It's a 2-hour class that talks about neurobiology, addiction in the brain. It talks about medications, behavior modification, relapse prevention. We also offer an 8-class Stop Tobacco program, which kind of follows the same guidelines as the workshop, but it's more in depth, and it's 8 classes, 2 hours each class. That's 16 hours of face-to-face time with patients. We give them a quit date, which is halfway through the program. It's very intensive, and patients do really well in that program.
So the quit date is not the first day of the program?
No, absolutely not. We build up to that quit date. We give them 4 classes to prepare, to get medications on board, to do behavior modification, change behaviors related to smoking, to get ready to be successful for that quit date. And then we continue to follow them for 2 weeks or 4 more classes after quitting.
So the program itself is about 8 weeks.
It's 8 classes.
8 classes?
2 classes a week.
So
over a
about
month.
4 weeks, and then you follow them out for another 2 weeks. So this is really a fairly lengthy process.
Yeah.
I know that in talking to the well-known tobacco researcher Stanton Glantz at UC San Francisco, many years ago he spoke at a hospital where I was running an education program, California Medical Facility at Vacaville, which is a prison hospital. In those days, we were just going smoke-free. And I remember he delivered a talk, and I believe, if I recall correctly, that he did emphasize the importance of deciding on a quit date in advance.
Deciding on a quit date is huge, because that's kind of a commitment.
All right.
But I think equally important is to make sure that you've got some medications to kind of support that quit. Because if you don't have a plan and you just are planning to quit, excuse me, you can go through withdrawal. And withdrawal is very, very difficult to deal with. And there's a 97% chance relapse going through withdrawal without medications. So a quit date is great, but talk to somebody, talk to your doctor, call me, let's get a nicotine patch on and really support that quit for a higher success rate.
We want to do better than a 3% success rate.
Absolutely.
Although I believe the majority of people who do successfully quit smoking have in fact tried and failed before.
Oh, for sure. There's studies kind of support that it can take up to 30 quit attempts before they're successful. And what happens is that people learn from trying and failing, and they learn kind of what that relationship they have with nicotine and where it fits in. And with each quit attempt, you are learning something, so your chances of being successful the next time goes through the roof.
You know, there maybe is a bit of a life lesson there, because that's true of so many other things.
Yeah.
You know, I mean, including struggling with being overweight or obese.
Yes.
You know, nutritionists we've had shows on nutrition and diabetes, and nutritionists often will say that, you know, often people have to try more than once to really alter their lifestyle.
Yeah, that's exactly. With smoking cessation, when people have failed in the past, it takes a blow to their confidence, and that sense of failure just grows. So sometimes people will not seek help because they feel they can't quit because of multiple failures. So people that are in that stage, we just ask, that's the time to have an expert kind of come in and intervene and help support and educate.
Very interesting. One thing, too, that Professor Glantz said in this lecture a number of years ago was, at least at that time, he suggested people change their brand of cigarettes prior to quitting, because he said, for example, many cigarettes have flavorings in them and so forth that encourage continued smoking. I don't think that's an approved, necessarily scientific approach, but he anecdotally suggested that. Do you see anything to that?
Oh, absolutely. In fact, that's part of our program.
Really?
We ask people to change their brand about 3 days before quit date. We don't ask them to do it 3 weeks before quit date, because it will become an acquired taste. If that cigarette with a different brand that maybe is not as flavorful as the brand that they initially were using, they will acquire a taste, whatever it takes to get that nicotine to the brain.
Very interesting.
So we'll ask them 3 days before quit date, and we usually get a lot of resistance with that because people don't want to change their brand because they're so connected to that. But it really peels away that what they're addicted to is truly just the nicotine.
Okay.
Right? You take away that pleasure of the flavor, the package. It's really just about the nicotine.
Very good. And do you assist people who may be addicted to other tobacco products, for example, cigars, or I guess you rarely see pipes nowadays, but
occasionally we'll have smokeless tobacco, people that come in that are using chew, cigars for sure, pipe tobacco, hookah pipes. Anyone who's getting nicotine from other sources are more than welcome to come into our department, and we'll seek help.
I know that hookah pipes are used in the Middle East and Near East, but can you tell us what they are exactly?
So a hookah pipe is, and you'll also see them very close to campuses, college campuses, but it's very similar to a bong for those who grew up in the 70s, where you're using tobacco or infused gels that have nicotine in it, and it's lit, there's combustion with it, and the smoke is then inhaled through water, and that cools the vapor, it cools that smoke, and people can inhale deeper.
And I believe people will share the same device. It's kind of a social activity.
It's a social activity. Sometimes there's shared mouthpieces, which event brings up a whole different health risk in that. But the main concern is that people have the perception that it's a cleaner smoke and that it's not as harmful, and that's not true. It's just as harmful and it's just as addictive.
Well, as long as we're on the subject of a cleaner smoke, I feel I would be remiss if I didn't get into the very contentious issue of vaping.
Yes.
Just as we were talking off air, I think I was mentioning to you that just this morning before our filming date today, there were news broadcasts on various television stations about efforts to limit the sale of vaping products in cities, flavored vaping products to
Yes.
children. And in fact, some individuals have suggested that the rate of vaping in high school could be anywhere between 10 and 50%.
Yeah.
So this is an emerging issue. Do you have any thoughts or insights on this for our audience?
First and foremost, anyone who's been watching the news, you know that the CDC has come out, excuse me, the CDC came out with a statement that if you vape, please stop vaping immediately, because we've had 6 deaths in the United States and close to 500 people with severe acute lung conditions related to vaping. And it's still under investigation, and we don't know exactly pinpointing what the issue is, but it's definitely an emergency at this point. So if anyone's vaping, please stop. But to address what else you have said, my personal opinion is the FDA was a little slow in reacting with regulating these vaping products, with regulating the flavored e-juice or the cartridges that people vape. If you go into any vape shop, you'll see flavors that are cotton candy,
Bubble gum, right?
yeah,
Yes.
Vanilla cupcake. And that's definitely marketing straight for those teenage people. So they're laying down the tracks of getting a nicotine addiction in their brain by that exposure of vaping. And studies are showing that over time, they'll probably be turning to cigarettes. So there's a whole new generation that's coming forward that's going to be addicted. And whether they're vaping or they're smoking, it's there.
I know that some literature, I believe out of Britain that I've encountered, has suggested that vaping can be an aid for smoking cessation as a kind of harm reduction strategy. But I totally agree with what you just said, Cari, and also I believe that in this country, unless I'm mistaken, I don't believe that reputable organizations of physicians or nurses have endorsed vaping as an approved smoking cessation strategy, unless I'm mistaken.
No, UC Davis recognizes it. It's not a smoking cessation tool at all. There are studies that show that any of the 7 FDA-approved medications for smoking cessation, we're talking about Chantix and the patch and things like that, that they are just as effective to use to help quit smoking. So why use something like vaping that now people are getting really, really sick?
Yes, and I believe also that the FDA has issued a warning to at least one major vaping manufacturer, or at least someone in the federal government, I believe to Juul, and I believe it surrounds the advertising. And you know, I have seen the advertising in newspapers, and often it will show someone giving a testimonial to the effect of, I was able to quit smoking after many years, and now I use Juul.
Right.
Now, it does not say we are marketing Juul as a smoking cessation product, but the implication is clear.
It's clear as day.
You know, and I personally feel that's quite disingenuous. I feel unless this has been approved for that purpose, to present it that way is confusing to the public, perhaps intentionally so.
I 100% agree, and especially with the statement coming out that we're in kind of this emergency crisis right now with people becoming very sick, and yet we're still seeing advertisements for vaping, Juul in particular.
And aside from people becoming sick, let's assume hypothetically that inhaling an electronic cigarette or vaping is relatively less harmful. Hypothetically, ignoring some data for concerns such as heavy metal toxicity and other things in the delivery devices of some of these devices. And also I've seen a case report of one that exploded that damaged the lip and teeth of a young man. I've seen that as a case report.
Yes.
So, but let's assume for the moment that it's still relatively safe compared to a cigarette. There's still the issue of the gateway effect. In other words, if you have a teenager who is not addicted to nicotine and that teenager decides to vape thinking it's relatively safe, well, you know, what is the likelihood that that kid will become a smoker? I mean, do you have any thoughts on that?
Studies support that teenagers that are vaping will more than likely end up using cigarettes. Yeah, so studies truly support that. And it's a way for the tobacco industry to just make sure that we've got a next generation of smokers as this generation starts dying off.
Okay, well, we try not to be too dogmatic in health focus, but I think we have a unanimity of opinion, at least among the two of us and some of these other organizations, that we do not embrace or recommend vaping.
Right.
We think it's good to avoid it.
Yes.
Okay. Let's talk a little bit about some of the tools for smoking cessation. Now, you mentioned Chantix. My understanding is Chantix really blocks the brain receptors that give the pleasurable result from nicotine.
Yes.
So that you smoke, you just don't get anything out of it.
Exactly.
Is it a useful tool?
You know what? It's very effective. Chantix has been extremely effective. It isn't any more effective than using any other combination therapies. And when we say combination therapies, I'm talking like using the nicotine patch along with a short-acting nicotine replacement, like using the patch with the nicotine gum or the nicotine lozenge for any breakthrough cravings. Chantix is great. It blocks those receptors. It also releases a lot of dopamine, which kind of mimics what a cigarette does. When you take a hit off of a cigarette, it releases a lot of dopamine and other neurochemicals that are very pleasurable.
Is Chantix available at all as a non-proprietary or so-called generic preparation?
So
I suspect it is not.
It is not,
No.
but if you have private insurance or state insurance like Medi-Cal,
Right.
it's covered. I mean, there may be a copay and it may be
Yeah.
big, but there's other prescriptions that you can get that are not as costly and are just as effective.
And let's face it, too, it's expensive to get sick. It's expensive to buy cigarettes.
Yeah.
Yeah.
Yes.
Nicotine preparations, do you like to use gum, patches, both?
Definitely combination therapies. Studies support long use, meaning the minimum of 3 months of any of these medications to help people quit smoking, and using a combination. So if someone was prescribed even just Chantix, I would recommend using gum or lozenge as something to use on top of Chantix for any breakthrough cravings that people may have.
And are there any other agents pharmacologically that you like to employ? I know that the chemical agent in Ambien, which is an antidepressant, was used. It had another name, I believe, when it was used for smoking.
Wellbutrin is
Wellbutrin.
another
Okay.
FDA-approved medication, which is an antidepressant, bupropion.
Maybe it's not the same as Ambien. Perhaps I'm
No,
mistaken.
yeah. And so using that, along with, typically we'll use that with the nicotine patch.
Yeah.
We get really good results, kind of across the board. But using medications is really great, but using medications along with counseling, behavior modification is the highest chance of being successful.
When you are running these classes, how many people are in the room? Is it a number of people together?
Yeah, we generally have about 10 to 15 people in a group setting.
And do you have a facilitator, a peer educator, a single teacher? Is it just you?
Yes.
I know you have a colleague who's also in
Yeah,
nursing.
yeah. So we have a full tobacco team at UC Davis. But who's teaching our classes? It's usually myself as a tobacco treatment specialist. I have a health educator that helps co-facilitate the classes. But we also incorporate like a multidisciplinary approach in that we have a pharmacy resident talking about the medications. We have a psychologist or a licensed clinical social worker coming in and talking about addiction. We have peer educators. Someone from a previous program, a patient from a previous program will come in and tell their story, their success story to our patients, which is very helpful. And then we have a dietitian come in and talk about how not to gain weight once you quit, and talk about the changes in metabolism related to nicotine.
So in that list of experts who help people with lung problems, we should include the registered nurses, the educators, and obviously dietitians, anyone else who's doing that. And your clients, patients, are they young, old, all ages?
So I'm working in the hospital setting.
Yeah.
So the people that come to see me, most are from a referral, so they're seeing their physicians, their primary care physicians, or sometimes specialty as well. And so generally the patients that come to see me are in their 50s, 60s, 70s, where they're starting to have the health effects from smoking.
Yes.
And that can be extremely motivating, and hopefully it's not too late before disease has happened. We have targeted undergraduates at UC Davis a few years ago. seeing if we could get some excitement about vaping or smoking cessation resources, and we didn't get a big response.
When you're young, you feel that you're immortal.
Exactly, yeah. Or they feel their perception is that they're not addicted and that they'll deal with this when they graduate.
Okay, as I look at the population here of students at Davis, I'm not really, mainly I deal with medical students and residents, but I get the feeling it's a pretty health-oriented campus.
Mm-hmm.
Do you feel that the rate of smoking here is similar to what you see in other locations?
Well, the rate of smoking in Sacramento is about 15, 16%. I don't know the prevalence on campus.
Mm-hmm.
There's a lot of international students.
Ah, okay.
And then there's a lot of faculty. So we're talking about maybe some older people.
And
so,
employees, of course.
And employees.
Yeah.
And so it is a smoke-free campus since 2016, I believe, the university. And so we know that there's people that don't comply with that policy, and we know that there continues to be smokers.
And I believe you have a pamphlet there, do you not?
Yeah.
Show us what that is and tell us a little bit about some of the instructional materials you use. I know some of them are also on PowerPoint.
Oh, yeah. So this is just our trifold. This is what we give our patients or any providers that want to know what we offer, and it just offers up what our classes are about.
And
just information.
Of course, that would be suitable for somebody who's kind of traditional. I imagine you may also have a website.
Yes, we have a website at UC Davis. It's livinghealthy.ucdavis.edu. If people can't come to our classes, then we refer them to the 1-800-NO-BUTS. That's at UC San Diego. The Cancer Center houses the telephone quit line in the state of California. And so if you can't come to a class, then our recommendation is, we can send an e-referral, and they can turn around and contact our patients and do telephone counseling for them as well.
So in this class, you have the verbal face-to-face interaction, you have traditional modalities such as pamphlets, and do you have other audiovisual aids? You have PowerPoint?
We have PowerPoint. We also will send ME videos. We could send ME videos through email or through MyChart.
Is there any documentation of what these classes are like on YouTube or anything like that? I wouldn't think so, but I'm just curious.
If they are on YouTube? Or we do not have our classes on YouTube. No.
That would be unusual. I'm just curious to know. Well, you've elucidated this program, and I would just say as a physician that it's possible to be what we would call penny wise and pound foolish, right? And every dollar spent on tobacco cessation, I think, is well spent, as long as it's not something outrageous, because tobacco, I believe, remains the #1 cause of premature death in the United States.
Absolutely. Yep.
And I think you're mentioning international students. I think a lot of the tobacco companies have, in fact, targeted third world countries. I believe the highest rate of smoking now, if I'm not mistaken, I think it's in China, isn't it?
I'm not sure, but there's definitely a target globally.
Yeah, I mean, I may be wrong about that. I'm just recalling that. But so let's get sort of to the bottom line. What is the success rate? Somebody comes in, someone's motivated and goes through your program. You said people who just try on their own without a quit date, maybe 3% succeed.
Yeah.
How much do you bump that number up?
So we have to define success.
Okay.
Because we look at smoking as a chronic disease. So is it abstinence? Is it prolonged abstinence? I've kind of did some statistics early on when we were doing the smoking cessation program in our cardiology department, and we would look at 6-month and 1-year smoking prevalence once they've completed a program. And if they complete the program straight out, we're about 99% success, but at 6 months we lose half. And at 1 year, we're down to about 25%.
If you compare 25% though to 3%,
that's good.
That means that you're doing almost an order of magnitude better.
Yeah.
Because you're doing almost 10 times better.
Right.
Yeah.
But with quality improvement, what we want to look at, because it is a chronic disease, and what happens if you relapse after 1 year? So with quality improvement, we want to look at engagement. We want to look at, are they using medications? Other metrics we want to kind of start looking at is, how many classes did they attend? And then did they follow up with attending any of our support groups after that? Because all of that is really a part pieces of that puzzle to make sure people are successful.
We're beginning to run short of time. If anyone wishes to get in touch with you, how could they contact you? Could they contact you via the website?
They can contact me via the website. Our department number is 916-734-0718, or my office number is 916-731-6838.
And as we look at the future of addiction science, do you have any closing thoughts? Do you feel optimistic? Do you feel that we're moving in the right direction?
We're finally moving in the right direction. There's nothing on the horizon that's going to be the aha magic bullet. I think what I truly believe is that we need more specialists, more tobacco treatment specialists. We need more policy. We need more regulation. Tobacco tax studies show that that is one of the most effective ways to get people to quit and prevent people from starting.
Cari Shulkin, registered nurse, thank you so much for joining us here at Health Focus. And more than that, thank you for the good work you do in helping people, empowering people to quit smoking and using tobacco products. I hope that we'll continue this conversation on another occasion.
Very good. Thank you very much.
Remember, here at Health Focus, we focus on your health. So we hope you have a healthy lung disease awareness month, and that any of you that need help in smoking cessation are able to pursue that. Until we meet again, all of us here at the studio wish you the best of health. Thank you for joining us.